Thank you, Vaibhav. Again, I don't have any experience in robotic hip right now. I will be talking only about the conventional techniques and conventional ways of assessing these lengths. So, restoration of normal hip biomechanics is the key goal. So, all this length version ultimately is to achieve stability. So, on table you are already committed to something. So, if you don't have stability, then whether it is long, short, it doesn't really matter. So, what is primary important is of stability. So, the techniques, whatever you do, is have to be like preemptive. So operating surgeon has four goals. Means whenever you think you need to restore the length, you need to maintain the femoral head offset, and you need to get a good access so that you're. So all this, if you have to achieve, that itself would probably give stability. That's why I said it is all preemptive. So once you are committed to something, then you have to only look for stability. You cannot, whether it is lengthening, shortening, you have to sort of commit to that. So, and with present systems of uncemented hips, we need to have a good metaphyseal fill. So your stem ultimately has to be rock solid inside and stable and in a proper version. So whatever length it gets. So whatever lengthening corrections you have to do, you have to plan preoperatively. So LLD is common after THA. It's very common. Even in fact, yesterday only one of my patients said that my one leg is short, and he's every time he comes to my OPD, he is showing me that he is limping. So although it is incidence is ranging from 1% to 50%, lengthening of the operated limb is more frequent than shortening, and mean discrepancy ranges from 3 to 17 millimeters. But generally around 10 millimeters is supposed to be sort of the drawing line where beyond which you need to worry. So discrepancy may be either. So then there is something what is called anatomical discrepancy or functional, the perception of lengthening. So if your abductors are very tight, you have just got, it was a very short hip and absorbed neck or head, then you have restored the length, you might have perception lengthening. So that is a functional this. And we need to have a clear understanding of all this, what actually is creating the sensation of lengthening or discrepancy. So patient dissatisfaction is very common. It is one of the most common reasons for litigation, at least in West, and I'm sure we all read about it even in our city very recently. So difference greater than 10 millimeters is often perceived by patient. So below 10, patient may not notice it. That is what I said. It is very common, may go almost up to 50%. So complications, increased risk of osteoarthritis in the operated limb, increased risk of aseptic loosening, prompt revision surgery, and polywear inside. You can see one of these patients, there is a slow polywear over a period of time. If your cup inclination also is different, if it is more vertical and you have lengthening, it can lead to early polywear. So acceptable limits, small discrepancy can, as I told you, it is perception also functional. So even less than 5 millimeters may sometimes cause functional perception. So you need to sort of understand, particularly if you are going to revise the other hip, then it becomes very important that you notice this. So limb more than 10 millimeter has been reported almost in 16 to 32% of patients. So as I said, preventive measures are very important because stability is the key. You're focused on stability. So on table, whatever gives you stability is the real length what you are going to achieve. So a well-planned acetabulum, a planned neck cut, and ensuring adequate length, neck length is the most important tools you have in correcting. After that, it is beyond your, it is only the stability which will guide you. So preoperative assessment becomes, although none of the companies gives us those what is it called templates. Yet it is very important. Now we have computer programs, we have softwares everywhere. We should sort of try to get the length preoperatively. It is very important and it really helps in the long run. So full length AP radiograph, even in case of hip replacements, is needed, and then assessment of the knee on your simple computer program, CAD program, can help you and guide you about the neck length. So planning a neck cut, planning the vestibular coverage would, even if you are not having the navigation or robot, can give you. So assessment of these angles and these lengths is very important. So if you have prior knowledge of this, simply going into and doing a total hip replacement, of course, you may be able to do a good technically, but then to have these values in your mind, in the back of the mind, is very important. So preoperative measurements become very important in such situations. If you draw these lines, even on a simple pelvic X-ray on your computer, so every hospital has now the software, and I think that would be very, while you're sitting in your OPD, you can do this, and then that will guide you into your post-operative measurements. So methods of restoral length: preoperative templating using tracing paper, which is not available. No company provides it. Intraoperative, and then doing it on your own computer becomes very, now we have palm tops, on phones, we can do it everywhere. So intraoperative identification of landmarks becomes very important. So computer assisted navigation, if it is available, you may now, it may change in the future over a period of time. I personally don't have any access to it right now. So first is acetabulum, as I told you, how much of lateralization, how much of medialization. So identification of the fovea is very important. You should not ream beyond that. Identify of the, what is the end of your acetabular reaming, that becomes very important. So I always follow the lips of the acetabulum all the time. So if there is good coverage on all the 360 degrees and your tal is still visible before you finally insert the cup, if you put your mosquito and see that your tal in the trial is still there, that means you have got adequate coverage and probably the adequate length. So beyond a point, we are all worried that we should have a good hold of the cup. But I think the conventional that you should see punctate bleeders, and then your fovea and the walls should be well merging, and a good coverage of the lips all around. Don't go too anteverted. I had a patient where I anteverted more and we got an anterior dislocation even in supine position. So all these parameters, if we do follow, we'll get a good cup position and inclination very often. Then reaming, tactile, visible and auditory clues while doing a femoral reaming is very important. So if you are feeling after the cup and your trial that your length is less or more, you can put a one size upper stem. Even if it is little pointing, jutting out, it can be. So that is very important, how much you go deep inside. So getting a good rotatory tactile sensation and seeing that how much depth you have, how much merging you have done with the canal is very important. So if the rasp sinks below the neck cut, shift to the next size. So go on hammering it till you feel that it has gone at least 2 to 3 millimeters inside your neck cut, then you can shift to the next size. So modularity helps in such situations. So luckily we have now enough sizes in most of the companies. They give at least 3 to 4 sizes of neck length, so that can help on table. So be sure that your neck length is restored, and if you have preoperative assessment, then you can probably sort of match it to that. So neck length adjusted, stability checked by telescoping, and telescopy more than 2 millimeters or dislocation, extending offset designs can be considered. If you don't want any neck length but you want to have more tight, more stable hip, you can reduce the offset and get a more similarly stable hip. So there should be no FFD, full extension, because many times under anesthesia, in fact, in spinal anesthesia, the patient is a little tight. If you can request your anesthetist to at least give a top up and see that you get a full extension on table, that is probably a desired position. So check for any impingement. So modular necks allow independent adjustments of length, but then you need to see that the stability is still maintained. So as Dr. Londe said, that intraoperative tests like shuck test, KICAS, whatever test that is called, they are not very positive. We have been using the chain, that pin, which we don't remove it at the time of femoral reaming, and yet considered as a measuring parameter. But all those are not very clear. So it is very important that we have a preoperative plan and have the parameters. I sometimes use a marker point on the iliac crest over top of your drapes, because that length doesn't change. So you can still do it in extension and see the length. So all these things give you a guide system to achieve the proper length. So shuck test, drop kick test, whatever, these can be considered. They should always be, you should all go through these motions and see them, because in conclusion, a stable pelvic landmark is very important during the measurements. So post-operative measurements, as I told you, if you're doing the other hip, you need to be very sure that next time, because first time you can be forgiven for lengthening or shortening, but the second time you have to be really equal, because then they start noticing it. So about 1 in 3 functional, I was talking about the functional lower, that is the perception. So in that case, the length is almost equal, but the patient has a perception of lengthening or shortening. So many times it over a period of time, it stretches, the gluteus stretch itself, and they get a good right feeling later on. So the gait, and this may over a period of time with strengthening of the abductors, it will over a period of time diminish. So offset is the horizontal distance or the vertical distance from the center of the femoral head, and so that has to be preoperatively assessed and to compared with the opposite side. And generally it is around 40 to 44 millimeters, and it is influenced by the neck shaft angle. So more vertical you are, less is your offset. And if that is what I said, if you have lengthening hip and you want to get it more stable, so you can increase the horizontal offset, and most of the companies do provide on table a lesser offset femoral stem at that time. So, if your neck shaft angle is more, then your offset is often decreases. So you can have that modularity on the table and get a better offset and more stability. So post-operative evaluation becomes important, in particularly in second hips. So insufficient offset can cause limp, require use of walking aid, induce instability. The femur is closer to the pelvis, motion range, so causing impingement. All those problems will come with improper offset and implant survival, as I told you in the first. So using a trace paper again becomes very important, which none of them provides. But you can specifically ask for a trace paper for particular implant. But with navigation and robotics now, these things will probably be solved. And as I said, that on your own computer, you can try to mark these. We have all these hospital softwares do provide us access to such tools. So assessing offset and two-dimensional templating becomes important in such cases. So as I said, if you have a neck shaft angle which is high, then your offset decreases. So your stability may be less, but you can achieve the same stability by increasing the horizontal offset and position of your cup. So if your cup is more lateralized, you can make it tighten, although you may not change the length of such cases. So measuring offset is very difficult because it depends on the positions of your X-ray. Normally we take in 20 degrees internal rotation, but CT method becomes the most important and reasonable in measuring offset. So on a plain X-ray, to assess and to produce it is very poor, because in different positions of rotation you might get a different offset. So as you can see in this no antiversion, typical antiversion, excessive antiversion, so the offset also changes. So assessing it radiologically is very difficult. On table, it's very important. As I told you, the stability should be respected, and to change the offset will depend on your stability. So strengthening, again, if your gluteus muscle is lax or tight, that can give you a functional feeling of a functional limb length discrepancy. So in such cases, modularity becomes very important. So you need to always tell your company fellow to provide other offsets and neck lengths. So use those implants where you can have these possibility of increasing and decreasing the offset. I think that's all. Thank you.